Fantastic. Welcome. Gina.
Hey, I'm Gina. I am a certified neuroscience nurse. I'm an outpatient practice RN at Sloan Kettering in the neuro-oncology department.
Great. And Chelsea.
Hi, yes, I actually work with Gina. I'm a registered nurse and I work in office practice in neurology.
Great. So I'm super excited, mainly because, you guys represent a very nearby hospital, but also a different hospital system. So thanks for joining us. Obviously, Sherese and I, talk on a daily basis. So it's good to have some outside perspective. John Bookvar, as always, may or may not join at random times during this conversation. It's always a pleasure when he does. So we'll keep waiting or posted for him. This is kind of a change in what we've been doing. This started as an interactive, patient-centered webinar where we bring together experts dealing with all sorts of, neuro-oncologic diseases in the time of COVID and really address the patient questions. COVID now, hopefully, and the news seems to support it, we're on the verge of a recovery. And so things are hopefully going to change, maybe not get back to normal, not immediately, but at least start heading back to some normalcy or at least comfort for our patients. But I wanted to start with just, have your practices been affected, even though we're kind of moving past it now? What have you been going through for the past, 56 days? And Sherese, obviously, we're in the same department, but why don't you give a summary of how, your nursing practice has changed?
I think mine's a little different because I'm also in administration. So I have not been able to see patients over the past 2 months, really, just because I have this administrative role and I'm in charge of staffing the advanced practice nurses in the hospital. But I will say a lot of the patients are still reaching out via email. We are still doing some telehealth visits. A lot of patients have left the city. And they call or email with any issues. There haven't been a lot of issues. I think everyone's just been lying low and getting their imaging elsewhere, outside of Manhattan. But it's just been quiet for us.
Yeah, I feel the same way. Gina, why don't you go?
So in our practice, we kind of worked to initially consolidate everybody. So, the neurologists and the neuro-oncologists worked together to put all of the necessary visits into like a 1 day per week per neuro-oncologist. So that way you only had one RN and one doctor going in at a time into the office to really prevent unnecessary traveling for healthcare workers into the city, which I think was a great decision. So they've been seeing really only the patients that we needed to lay eyes on in the clinic. People who needed either LPs, outpatient, that kind of thing. So I think that's been working out really well for us. And otherwise, we've just been seeing patients on telehealth, which, has its pros and cons, but that's a whole different subject.
Yeah, I want to get to that as well. Chelsea, why don't you fill us in on how your practice has changed, and we'll circle back to some of the points you guys are bringing up.
So basically telehealth, it's kind of been amazing to see the fast transformation from seeing patients in clinic to seeing patients virtually. And I also think that it's really amazing how quickly the nurses that I work with have to adapt to just the new way of working. Basically, just triaging over the phone has become something a little bit different now that it's within your home. I do think that it's emotionally a lot more taxing because we are alone and you are dealing with these patients over the phone and you don't have the support from people being around you. Really knowing how to reach out to your resources. Just figuring out how to do everything virtually over the course of a day, really. So that's been a lot.
Yeah, can you elaborate on that a little bit? What do you mean by being alone? I mean, do you mean the doctors are kind of remote and you're remote and handling things yourself, or?
Yeah, so as Gina was saying, we actually only go into clinic 1 day a week. So the rest of the week we work from home.
Okay.
So they give us access to our systems, our healthcare system, to be able to access from our own computers. And we have been using different devices like Jabber to now use to communicate with patients over the phone.
And are you guys getting a lot of emails from patients? Is there a lot of anxiety about this?
Yes, it's out of control. It's a lot.
Really? Go ahead. Tell me about it. What do you get hearing?
I mean, of course, I mean, I think initially, like, it was just like, people were just so scared. And because there was a little bit of an unknown, I mean, the CDC didn't really direct us. It kind of gave like a very vague overview of what the restrictions and whatnot were. So people were calling because their family works with somebody who tested positive, and they all live in a small studio, and there happens to be 4 people that live there. So managing people really at home, and that was like kind of the whole chaotic feel, I think, that initially had started, because there was so much unknown, and you know, how many days it took for people to present, if they even had symptoms at all. And there was just a lot of fear and chaos.
Yeah, Sherese, same thing in the emails you were talking about?
Yeah.
What kind of questions are people asking?
A lot of my patients were asking if they should leave. You know, should I leave and go to Florida for a couple of months? Should I go to the Hamptons? Can my grandkids visit? Can my wife sleep in the same room as me? You know, a lot of patients are on chemotherapy. So they want to know, you know, if they're more susceptible for getting sick and things like that, just because their immune systems can be compromised. So that was a lot of the angst in the beginning. And I think for my patients, I feel like people settled down, and I think people realized that, you know, we're all in this, and we're all scared, and we're all affected, and you know, it's just all around us. So you know, I think people just adapted and just did their best staying in. But in the beginning, it was very overwhelming.
Yeah, absolutely. And so what about people who need things like visits or, you know, imaging you brought up before? That's a big thing where there's no real way to do that telemedicine, you know, in a telemedicine fashion. So how are you advising patients to deal with that?
I mean, people have wanted to stay out of the city, our patients, so they can either go to one of our sites, you know, on Long Island, or they can go, sometimes they call an imaging place near them, and they'll call and say, is this place okay? You know, and they'll say there are no patients in the waiting room, and, you know, they just have limited volume there. So we'll let them do that, and they'll just mail the disc to us.
Yeah. And so, you know, how do you recommend people confirm the safety of a site they're going to? Any of you guys, obviously.
I think that's a major challenge, like for us, I mean, specifically about going to these local facilities, there's kind of like some uncertainty with that. You really can't, there's no way to be able to tell somebody that for sure the site that they're going to is safe. So, you know, you kind of have to go into that with a lot of faith in the healthcare system, that they would be treating them as good as we would in an oncological facility. And I think for the most part, New York has like adapted very well to that. Getting them to their MRIs, getting scans back from the facilities is a whole nother challenge. I think that we're also learning how to navigate, like getting imaging back from facilities at local hospitals is like a major barrier. But yeah, I think that you have to really put a lot of faith in the healthcare system and know that coming into the city is a whole nother, a very dangerous thing for these patients. So hoping that staying locally would be even better for them.
Yeah, especially when they drive. You know, a lot of our patients who drive, who say live on the island, they can drive. Like one of my patients who was just starting radiation when this began, we had to change his treatment plan for him to get radiation instead on Long Island. He said, instead of me getting on the subway there every day, you know, no one wants to be on the subway. I can just drive my car to this facility on Long Island and get the radiation. So we had to make that adjustment for him.
Yeah. And I think, another factor of it is this is like a already highly anxious population. They're already dealing with diagnoses of brain tumors that they're not really, that's a very confusing diagnosis. And I think that there's a lot of fear associated with that initially to begin with, and then you add the layer of COVID on top of it, and we don't have the answers, and then we have to adjust their treatment plans based on it. So there's a whole nother added layer of fear to that and confusion for them, I think.
Yeah, I mean, the things you guys are mentioning bring up about a million different questions. I guess the first thing is, are the doctors concerned about the cancer diagnosis? Obviously, there were some guidelines initially that said people with cancer are at a higher risk. There's actually a study today that's being, publicized widely on a lot of the news channels that there probably is a susceptibility for cancer patients in COVID. They're doing more poorly. There's a higher risk of a negative outcome. For brain tumor patients, I'm not sure. I haven't read that study yet specifically, but I'm not sure that we know that that's a certainty, right? There are risk factors with the chemotherapies that you're on, where your white blood cell count gets diminished to some degree. I know there are groups, including ourselves at Lennox, looking at whether or not that actually offers some sort of protection from this kind of enhanced immune response that contributes to the COVID disease. But how are your doctors, how are they guiding patients? How are you guys guiding patients who, have both the diagnosis of cancer and the fear of COVID?
I think it's really important that we instruct the precautions for everybody to take, and instruct to stay inside as much as possible. So I think exactly what we were talking about. I mean, getting imaging locally, getting labs locally, switching everything virtually, seeing people over like any means that we are able to see them. I mean, it's all about prevention. And so, and as Gina was saying, like, we can't guarantee that other facilities are taking the precautions that we are, but we can at least instruct the patient and the family and tell them what precautions that they have to take, because ultimately, they need brain scans. We need to monitor them by imaging. So we can't tell them that they can miss. I mean, and also, we're delaying scans as long as we possibly can too. So we're really keeping people inside. And I think that's the main goal that we're doing, preventing people from getting it. And just across the board, both family members and patients.
Yeah. So, take it seriously, basically, but you can't neglect your cancer diagnosis and your cancer treatment.
Right.
Yeah.
So, one thing that you mentioned, I think, Gina, was that it's dangerous to come into Manhattan. And I'm not necessarily sure that's true. And this is something that I know John Bookvar and I have discussed a lot recently, where, we have the most experience at this point with COVID. Our hospitals are probably they've taken crisis measures to the extreme, and we've really put in procedures and algorithms that can keep people safe. And I think I'm comfortable telling people that, no, actually, you know what? You're safe to go to the hospital right now. We've got this down. Do you think that other places now are kind of lagging behind that? Do you think it's actually safer to probably come to Manhattan or come to, a Sloan or a Lennox, one of these big name hospitals that are at really the epicenter of this?
Yeah, it's a good point. Definitely we're pretty well versed in how to manage these patients at this point. I think there's just inherent risk with coming into the city, whether it be getting here by subway or just, being in a more populated area. We definitely have a good handle on appropriate precautions to take. But like I said, there's I think there's, a greater risk of just coming into the city, for exposure purposes, that you might get at a facility, I don't, it's a good question though. I don't know if it's hard to say when you haven't really seen what's going on in the local facilities and understand what they're doing there.
Yeah, sure. What do you guys think? Sherese, Chelsea?
I agree. I think it's just a travel thing, and commuting here and taking public transportation. If people can drive here, I think it's better, but I don't think it matters which borough you live in. I think it's just the public transportation that you should be more careful.
Yeah. All right, let's talk about telemedicine. Pros, cons. I've got mixed feedback. I'll tell you that the doctors love it. And it might just be a surgeon-related thing because you can sit at your desk with all your imaging and all your toys and everything. But from a nursing standpoint, you guys are the ones on the front lines talking to these patients every day, receiving emails, participating in the telehealth. Tell me what's good. Tell me what's bad.
I think that when it goes well, it goes very well, and it's amazing. And, we were talking about public transportation. The patients love it. They don't have to pay $65 for parking to come into the city. A lot of these patients are hemiparetic. It's really difficult for them to transport around. So I think in that sense, it's a really great thing. But when things go wrong, it's not easy. And I think that coordinating, everybody to get on the same page, getting the patients there at the right time, the applications, using a lot of communication between the team, like the coordinators who help you with your setting up the Jabber calls or whatever platform you're using. There's a lot of communication breakdown that can happen along the way. So I think that it's really important to keep it streamlined. And that's definitely been a challenge. I mean, over time you would adapt to it and learn how to use it and things would get better, but we've kind of all just been thrown into it. So we've definitely had a lot of speed bumps along the way.
Yeah, there's a learning curve, I guess, right?
Yeah, absolutely.
Chelsea, Sherese, anything?
I find that it's been really challenging so far. I think just now managing everything through the computer, I mean, like straining on your eyes. I mean, I actually wasn't fully prepared. I didn't have a mouse for my computer. I have like an older laptop, so just like having the right technology is important, and that's not something that you can just like switch as easy. But there is something about also being alone, as I was saying before. Like if you were in clinic and a patient was sick, you can at least ask somebody, hey, can you help me and like address other things? It kind of seems like you really have to focus on one thing at a time, which makes it harder to, like if something's urgent that's pending, like it's hard for people to get to you. I don't know, there's parts of it of just like learning how to shift your work and balance everything out that I find a little challenging to start. But again, we're adapting and learning how to do that. So.
And is the clinical volume down so you have a chance to learn this? Do you feel like there's really not a lot of patients coming through? It's giving you an opportunity to kind of flesh this out a little bit?
I don't think my clinic volume ever really decreased too much. It's stayed pretty consistent. Every clinic worked a little differently. And as for mine, we actually just shifted everybody to telehealth. We didn't, like some doctors canceled some visits that weren't pertinent, whereas other clinics were just fully switched to telehealth. So it depends on which doctor. Everybody did things a little differently.
Yeah, sure. One positive to it, I'm a big fan, but I'm sitting in a really nice room with a nice computer and a nice camera on it and a good Wi-Fi connection. But one of the great things about it is that, and I think Dr. Bookfar had an experience with this today, you can bring in these other specialists and it makes a very comprehensive visit possible. And so, patients are able to speak not just with their neurosurgeon, but their oncologist and their radiation oncologist. If there are any questions, you can bring them right in the call. And that's something I know we're doing at Lennox now, making it, a very comprehensive kind of visit. And I don't know, are you guys doing similar things? Are you bringing outside kind of specialists in with your doctors, or has it been primarily just a doctor right now?
I think that our clinic system usually is generally email based. A lot of consults go through email. A lot of information gets sent through email. So in that sense, it was actually kind of pretty streamlined to readjust over to telehealth. Just connecting with people through email. We were pretty, it was a pretty gentle transition into that. I think where the real barrier came in was just figuring out how to get patients on the same platform as us, on the same level as us, really understanding who's important to be seen, how long we're going to be doing this for, do we see everybody? Do we see the follow-up visits? Where do we prioritize things kind of? And Chelsea, you said that your clinic didn't really change. I think that mine really did. We were trying only to see patients that needed to be seen within that, their 3-month scan follow-up or whatever it be.
Mm-hmm. So how long do you think this is going to last? I mean, like I said in the beginning, we're kind of focusing on recovery now. We're trying to. What does your guys' recovery look like?
I think this is like the most challenging question, and this is what everybody wants to know because it's been interesting, and it is a little different clinic to clinic, but some people, their 3 months follow-ups are already telehealth, and it's scheduled for July. So I do think that this is the beginning of something that we're going to be using. I don't, regardless of coronavirus, I do think that telehealth is the future. And I I think that this is just the beginning of telehealth. I feel like there's no like ending to this, because this is just the beginning, really.
Yeah.
Yeah, I foresee this kind of being, I was talking with the neuro-oncologist who I work with, and he was saying, I think that this is exactly what we needed as far as the push into telemedicine goes. You can see patients who haven't progressed. You can see patients who don't need, a human contact for their visit very easily through telehealth. And like I said, you have patients who are, they have hemiplegia, like it's difficult for them to travel into their visits. So for our patient population, I think that it's like a major barrier that we jumped over. So I think that we're just seeing the beginning of telemedicine as far as that goes. But as far as COVID goes, it seems like from an inpatient perspective, things are kind of settling down a little bit. I know that we have our daily updates with how many patients we have admitted, and I've definitely seen that about decrease by double the size in the last 2 weeks. So that's a positive thing.
Yeah. Sherese, what do you think? I know you and I have talked about patients coming in the office versus telemedicine. Who should be coming in? Who should we see?
I mean, my opinion is we should try to still do as much telemedicine as possible. I don't know how long, maybe the next, I would say at least through the summer. It's definitely still out there. Like, yes, it's getting better, but it's definitely still there. It's still spreading, much slower. But I think at least until the fall, we should see as many patients as we can by telemedicine. Limit the number of people who we need to see physically, limit the number of people who need to be around each other in the waiting rooms. We just don't know how long it's going to last, but it's definitely not over yet.
Yeah, I mean, listen, surgery, and specifically neurosurgery, tends to be a very kind of intimate act, right? And I'm sure you guys have experienced patients want to see their surgeons, and surgeons want to see their patients. We feel good when someone does well. We feel good when we've done a surgery and helped someone and gotten them better. And especially, you feel a certain connection to someone, especially if they have a disability. Gina, you keep mentioning people who are hemiplegic. Neurosurgery patients are a unique population that the outcomes sometimes can be fairly devastating. And you want to see those people face to face. And I think there is absolutely, a place for those patients to come in and see their surgeon. I agree with you, though. I think right now it's about patient safety, especially as we figure out whether or not cancer patients are at a higher risk, which I think the data is suggesting that they are. It's about staff safety, right? You've got older surgeons, you've got older nurses, you've got people you got to keep safe so that the hospitals can keep running. And those are all, very serious considerations. I don't think that people, one thing we've tried to do with this conference is kind of calm the fears that people have and the anxieties. And I think it's important to really stress that that's still the point. I think let us deal with the kind of the how we're going to do it and how we're going to keep you safe. But just know that the cancer care is there, right? And everyone's committed to providing it. And you've got a disease that's bigger than COVID, and that really does require your attention. I don't know if you guys echo that sentiment, but I think that's kind of where I stand on this as someone in Manhattan. So I guess, what are you guys doing for Nurses Week?
Well, for us, yeah, we have postponed our Nurses Week celebrations here, probably until the fall. We'll do a few small things this week, but we had huge things planned this week because I don't know if you know, Randy, but this is the year of the nurse.
The whole year?
The year of the nurse. So we had big things planned this year. It's a 200th anniversary of Florence Nightingale. So it's a big year. So we're just going to wait until the fall. We didn't want to take, here at Lenox Hill, we didn't want to, just because we've been through so much together and in the last couple of months with multiple disciplines, we didn't want to take anything away from the other disciplines. So we're just going to celebrate at a later time.
I think you bring up a good point, Sherese. It's kind of like nurses have gotten a lot of attention in the COVID crisis, but we tend to forget that there's a lot of respiratory therapists and occupational therapists and a lot of other people that have had a real hands-on, even more so sometimes a nurse's approach to COVID, and they deserve a huge shout out for everything that they've done.
Yeah.
So maybe it should be all disciplines week instead of nurses week.
Well, I think actually, you know, the nurses year couldn't come at a better time and a worse time in a way, because I think by the end of this, without a doubt, it's going to be nurses year and first responders year, and you know, everyone should get one at this point. Have you guys been redeployed? I know, Sherese, you were redeployed administratively, which is obviously a very crucial role. What about you, Gina or Chelsea?
I picked up a per diem position actually at NYP where we used to work. I was previously an employee there, so they kind of had a need for employees who had left within the year to come back. So I redeployed there, and I'm there 3 days a week now. So it's kind of been interesting to get a view of what's happening outpatient and also what's happening inpatient. It's been kind of like a unique perspective to really understand, and it helps me to be able to bring it to my outpatient side of things and really give people answers, because they want to know what things look like. And if you were just standing from the outside looking in, you might not see that things are still pretty bad inside of the hospitals. And we definitely need to give ourselves time to recover from that.
What kind of things do people ask you, or what kind of insights do you feel it gave you?
I think that, you know, patients, family members, friends, they all want to know, like, when can we go back outside? What does this look like? And, you know, you see other states opening up and you see things kind of returning to a sense of normalcy, and people get a little bit eager and they're thinking like, well, I don't see ambulances in the streets anymore. I don't hear about, you know, my friend's grandmother who's in the hospital anymore. But the truth is there are still a lot of patients that are being managed from a critical care perspective. And I think that it's important for people to realize and recognize that even though it doesn't look like it's, you know, at our front step, it's still, you know, it's still there, and we still need to be careful because our healthcare system can easily be overwhelmed by this. And right now we're still trying to manage those who are, you know, suffering from the first wave of this.
Yeah. Chelsea, what about you? Were you redeployed?
No, there were a few shifts that we were able to pick up to screen anybody coming in through the lobby. So there was some screening shifts, but I haven't been redeployed otherwise, just more keep them home.
Manning the fort then.
Yeah.
Well, I mean, I try to limit this to about 30 minutes, keep people's attention. I can't thank you all enough. I think this is very insightful. It's really, really great to have you all on, especially from different institutions within the same kind of epicenter. Any final words from anyone? Anything you want patients to know or people watching to know before we sign off?
Just, we're still here for you, neuro-onc patients. We're still here. Still.
Great.
Thanks, Randy.
All right. Thank you so much, all of you.
Happy Nurses Week.
Happy
Nurses Week.
Nurses Week.
Take care.
Thanks, guys.